Yeah. Hello, everybody. It's with great pleasure that myself, Ian McConaughey, and Jeanette Turner are chairing this particular session of great interest. My few words are, can you hear me at the back? Can you hear me at the back? Yes. And then, why are you at the back? So come forwards, please. Enjoy. Look at the three eminent, and I should also say imminent speakers who are going to be presenting. As ever, there are the basic rules: no mobile phones, or switch them off rather. If your companion bursts into flames, gather at the meeting point. You may or may not wish to take any valuables with you. And thirdly, please be interactive. Have you all downloaded the app for the conference? Hands up, all those who've downloaded the app. Okay. As I can see, the people at the back haven't bothered. Marvelous, good, well done. Oh, you have? Okay. Please download it, because you'll find the agenda, and on each one of the sessions, you can rate the session itself and leave comments. And we really want your thoughts. The gathering of this conference, successful, more successful it looks than last year, is the interaction between different people. And there's an awful lot of learning that comes out of this, as well as new friendships being made. I think that's right, isn't it?
Absolutely.
That's what I'm told. So please Twitter away to your heart's delight. Now, we've got three speakers, and I'm going to ask Jeanette now, who is the expert in urgent and emergency care, to put this into context. Thank you.
So I'm not an expert in overcrowding. I am an expert in EMS research. That's what I do at the University of Sheffield in England. So today's session is about crowding in hospitals. And you might say, well, what's that got to do with EMS? That's a hospital problem. That's not an EMS problem. But of course, demand, as everyone knows, internationally has been rising in terms of requests for help from EMS services. And a substantial proportion of those people end up in hospital. And they all contribute to what I'm sure is going to be the key word from this session, which is around flow and how we make people flow through that system that saves a life. So we have three eminent speakers, or I'm told one toe rag, to talk to us about their own experiences with how EMS can help to manage crowding in hospitals. Each one of them will have a little bit of time at the end of their talk. They've promised faithfully they will stick to time. So we can have a few questions at the end, and then hopefully right at the very end of this session, before we go off for lunch, a broader conversation with those of you in the audience, some of whom of you will have your own experiences of this, and it would be really good if you have some questions for us and also some comments so that you can share those experiences yourself. So, who's up first? Jerry. So we have a US perspective, a Danish perspective, a UK perspective.
Thank you, Jeanette. Good morning again. It's actually very interesting for me to see this many people in this room for this particular subject. I think it shows that the times are changing, and indeed they are. My perspective, or my objective this morning, was to provide an international perspective on what's going on as far as demand and overcrowding, and it is indeed a global dilemma. You know, from the EMS side, I'm going to talk about the EMS side first. What we're seeing is resource depletion, response times going up, and patient care compromised. As president of the International Academies of Emergency Dispatch, we have what we call navigators across the globe. We have 7 different navigators. And each one of those, I've measured what's going on. In the United States, we're seeing an increase of 6 to 7% demand average across the U.S. In China, we had a navigator in Suzhou, China. We're seeing an increase in 10%. This is Hamad Medical Center in Doha, Qatar. They provide service for the whole country of Qatar. Their increase is 11%. And our Asian navigator in Kuala Lumpur, Malaysia, is an increase of 10 to 12%. So you can see the trend lines here. And then, of course, there's London. Who's here from London? You guys, oh my God. I spent a lot of time in London with London Ambulance Service, and not only is it like this, but you see headlines like that from the past mayor, right, guys? I mean, this is a global dilemma. Recently, the The accounting office for the NHS in England released some figures, and I think this shows this particular demand going up, what's going on in England from 2009 and 2015-16. And what's interesting about this increase in demand is also this next slide. And this shows the response time targets struggling and, in fact, going down. So this shows that direct correlation that we're talking about. As demand goes up, response time's going down because the resources are being depleted. Well, the why, I think we're relatively familiar with the why, but just to review, we know that 40% of our transports in EMS anymore are for those aged 65 years or older. And the fact of the matter is 4 times the utilization, and one of the factors of this is the comorbidities that go on with the elderly population. The other driving factor is, in fact, that there's rising expectations in EMS, and there's limited access to EMS because of and lack of primary care. And that's not just in England, it's not just in the United States, that's across the globe. In fact, the report Taking Healthcare to the Patient showed the reason why. That 10% of the patients ringing 999 in England were having a life-threatening emergency, but a majority of the calls, in fact, in this particular case, large numbers were social care needs and mental health problems. This is evidence-based. This isn't just, again, from the NHS in England. This is from the this is data from New York City in the United States, which shows, and the arrows point to this, that in fact, that blunt trauma and trauma calls are decreasing as a percentage of our total call volume, and what is increasing are calls like mental illness and general illness. And this was published in Pre-Hospital Emergency Care, which is the peer-reviewed journal for the National Association of EMS Physicians. So that's why when we see things like this, we're seeing things that are non-acute patients, but causatory factors to what's going on in EMS. And this is from Scotland. You know, again, these are not acute care calls, but this is making headline news across the world. So that's on the EMS side. Now on the hospital side, we were seeing an increase in hospital diversions, EMS wait times, and patient wait times. I was a member of the Institute of Medicine Committee, in which we were required to issue a report to the United States Congress, in which our data that we gathered shows, in fact, fewer emergency departments, fewer hospitals. At the same time, ED visits are going up, which led to this in our report, that 40% of the hospitals reported overcrowding. Boarding is a problem for patients waiting 48 hours, and ambulance diversions reached 500,000 diversions in 2003, and that's going up. Is that just US-based? No. Again, going back to January of this year, from England, this is from the National Audit Office, 500,000 ambulance hours are lost each year in England. Think about it, 500,000 hours lost, 41,000 12-hour shifts are being wasted in England because of problems within the hospital. And that's why we see headlines like this. So the why for hospitals, I think we need to take a look at the why. We've looked at the why for emergencies, for EMS, the why for hospitals. Again, I was a part of this committee. In our report to Congress, what we saw was inefficiency in hospitals in the United States. The on-call specialists are unavailable because, frankly, they don't want to be on call. We see fragmentation within the hospitals and amongst the hospitals as far as regional flow of patients. And interestingly enough, no surprise to anybody in EMS, hospitals are not necessarily accountable. Hospitals are not necessarily accountable. And so what that leads to within the hospital, what we found is this diagram from our report, that in fact you've got high patient volumes leading to admissions bottleneck and an inefficient use of both hospital emergency departments and the hospital departments as far as inpatients. So when we see headlines like this, I find this a very interesting page out of the news from the UK. NHS facing worst start to year the year ever, but then the next article down, medics too stressed to work. Boy, I tell you what, if that isn't two articles that belong together, I don't know what is. They're causing stress on us. So, and why globally? I was just in meetings last month in which Ghana, same issue. Iran, same issue. Turkey, same issue. And this is really interesting. This is from Addis Ababa, Ethiopia, in which they looked at the causes of overcrowding. The patients in emergency care and the emergency, only 1.5% in Addis Ababa did they have a true emergency. The highest percentages was throughput component in the emergency rooms and the output component as a cause of ED overcrowding. So it's not just Europe. We're talking about Africa with the same problem. So what do we do? What are some possible solutions? This is, again, from the National Audit Office that recognized or actually proposed 3 solutions about 4 or 5 years ago. Doing more hear and treat, do more see and treat, and do more alternative destinations. Is it working? And I think that's the question, is it working? Because the National Audit Office now, which issued the report after looking at this from several years ago to January of this year, did find, in fact, that the estimated cost avoidance is 86.7 million pounds for hear and treat and 7.1 million pounds for see and treat. So they're having an impact. Beginning, the see and treat and hear and treat on the lower acuity patients are really beginning to have an impact. We looked at this same thing. This is a study that we did that was presented to the European Society for Emergency Medicine. I was one of the co-authors of this study, in which we took 4 different ambulance services trusts in England. And what we saw was, when we're looking at a huge volume of calls, looking at the percentages that could go to secondary triage, and then the percentages from secondary triage that could be actually done in hear and treat, what we found was in over 2.5 million calls, 9% could go to a secondary triage, and 54% could go to a hear and treat desk, saving approximately 22 million pounds as far as our study was concerned, and significantly, that amounted to about 134,000 unit hours being saved by going through a see and treat and hear and treat process. So it didn't reach the 500,000 unit hours being lost in England, but this is about 22% of what we found. And our conclusion was, in fact, things like hear and treat are, in fact, working, and that ambulance responses can, in fact, save additional unit hours. And what we did mention in this study was the downstream savings that could be created by efficient hospital utilization. Jeanette Turner, who was just up here, did this study, and in fact found that for hear and treat, callers were satisfied, the ambulance service nurse advisors had a positive experience, and it was cost effective if the 4 findings that Jeanette found were strong leadership, knowledge of local health and social services, and appropriate training and fit for IT training. And we found the exact same thing at the IOM. The exact same thing at the IOM. In our recommendations on how to try to create a solution to this problem, IT improvements were going to be necessary to enhance patient flow and to be able to do regionalization of on-call emergency services. And in fact, in our country, in the United States, JCAHO, which is the accrediting body, should reinstate strong standards to reduce and ultimately eliminate ED crowding, boarding, and diversion. Is it happening? Absolutely not. Absolutely not. We're still struggling. So I think how to achieve this vision, part of our recommendations to Congress was, in fact, that we come up with an integrated type of system with demonstration projects. And we asked Congress to do funding of certain demonstration projects. And the first demonstration project was conducted in Reno, Nevada, in which it found that they got a $9.9 million demonstration grant to be able to try and do these alternative solutions using community paramedicine, using ambulance transport alternatives, the same thing that was recommended by the NHS for England, and the Nurse Healthline. The video I'm going to show you is a video of what's being advertised or what there is on television. Now, one thing I want you to remember is, in this video, is that this nurse hotline comes into a 911 center. So you've got one pair of nurses answering both the calls that are lower acuity calls from 911 and these calls.
Ouch! fevers, sore throats, headaches. Ugh. Call the Remza Nurse Helpline at 858-1000.
Now, a serious head injury, that's an emergency. Call 911 immediately.
Earaches, nosebleeds, colds. 858-1000.
There's only one reason to call 911, an emergency.
But there are hundreds of reasons to call the Remza Nurse Helpline at 858-1000. Find more reasons to call at nursehelpline.com.
Again, those calls from 911 and from the hotline are coming to exactly the same communication center to ensure a coordinated effort. And this is the headline, it's paying off. In an alternative solution in New Jersey, they're taking lower acuity calls and leveraging clinical support systems for post-discharge patients. So again, nothing to do with 911 calls. They're using in their EMS system this for post-discharge patients to reduce the high risk of readmission and the high cost of patient cohorts. Remember, I talked about cohorts amongst patients, and they're doing care bundling management to keep the patients out of the emergency department. So this is an emergency medical services system that's taking a completely different approach, not even addressing 911 calls. How do we prevent readmissions and cohort care bundling? And that's working. And then one system that's beginning to bring this all together in our country is MedStar, which is in Fort Worth, Texas. And in fact, they're using a multiple systems approach using 911 nurse triage. They're identifying their high utilization patients. We call them their HUG program, high utilization EMS loyalty, and they have seen 507 patients that are high utilization patients during a 12-month period, a 40.3% reduction in emergency department use, 53, and after they've graduated from the program with integration with social services, 53.7% reduction in 911 use, 76.1% reduction in system abuse, keeping him out of the emergency department, keeping him away from calling 911. And part of the program is, again, just like what's going on in Long Island, readmission avoidance by looking at their CHF patients, their cardiac patients. How do they go out, be proactive in the community so they don't enter into the system again, using community care paramedics, and getting articles like this. Innovation breaks the cycle of rehospitalization, reducing these types of situations. And they've even come up with a hospice revocation avoidance for hospice patients, so that patients who are in a hospice situation don't call 911. They call another 7-digit number, a proactive approach that is really patient care oriented, that keeps them away from hospitals. So it's not just the United States. In Sydney, Australia, they're seeing results of being able to keep patients away from calling 911. New models of care in Wales. Anybody here from Wales? They're doing a great job in Wales. In fact, they're addressing their frequent callers. They have identified 29 social service agencies to be able to integrate, think about that, coordinating 29 social service agencies to be able to keep patients away from the emergency department and out of hospitals. They have nursing home teams that go into the nursing homes and work with nursing home staffs to keep the patients in nursing homes. And very innovative, they recognize that 5 to 10% of their calls are coming from police officers at the scene who are just calling for the ambulance. They've actually positioned their team members and have an agreement with the police departments in Wales to position their member with the police department dispatcher to be able to circumvent that call coming into the ambulance service when that call doesn't need to come into the ambulance service. Is this working? I think this is an interesting statistic, again, from the National Audit Office. We're talking about the emergency department, arriving by emergency department by ambulance has increased from 48% to 52% in 2014 and 15. But this indicates, based on their other statistics, that ambulances are increasingly taking the most appropriate patients to the hospital by looking at these alternative methodologies. New technologies. This is for the future, but we need to be able to look at what we can do with new technology, self-service care management. I don't know if you're aware of this, but I've actually seen this, where you talk into a phone and you tell them what your condition is, and automatically the bot provides you with an algorithm. So it's automatic. You're interfacing with a computer to manage your care. Distance monitoring with telemedicine and other types of distance monitoring, using different types of social media. The fact of the matter is, even drones may play a factor in this. Drones are being used for cardiac arrest patients, the delivery of AEDs, but how about the delivery of prescription medications? I mean, I don't think we really realize how far this can go as far as technology is concerned in the next 5 years to begin to manage the patients. But at the end of the day, how do we avoid overcrowding? That's the message of this particular session. I think it comes down to us, and it's the concept of integration. And when I talk about concept of integration, this isn't new. This was published by the EMS Agenda for the Future in 1996. The European Department, the World Health Organization recognized integration and recognized how important EMS was as far as integration is concerned in its framework for change. When we look at demand side changes and supply side changes and wide societal changes. Freddie and I were both part of the European Emergency Data Project. And in the European Emergency Data Project, we talked about integration with other providers, with local healthcare is going to manage this. And NHS England talked about integration and improvement of the Ambulance Services Trust should look at defining a new way of approaching out-of-hospital care. So I'll leave you with this slide. This is from our work at the Institute of Medicine, defining the new system. The fact of the matter is, we're not just EMS anymore. We're part of healthcare. And we need to recognize we're part of healthcare. In fact, are we EMS, are we providing out-of-hospital care? And that's a difference, because if we're really providing out-of-hospital care based on the percentage of patients who have lower acuity conditions. Jeanette Turner has quoted the fact that only 0.5% of the patients in England are cardiac arrest patients. What about the other 99.5%? What about those? And that's who we're taking care of. And that's why we need to be at the table, because this is a continuum of care that we're providing. This is not silos. This is not fragmentation. We need to understand that we're healthcare professionals, just like all the other parts of the healthcare system, providing provision of clinical care, and we need to be integrated into the community. So, in conclusion, we are not we're not siloed. We need to be at the table. If we're going to prevent overcrowding, we can have an impact, and we need to understand the dynamics that can help us provide that impact. I'll close you with this. The American humorist Mark Twain said, there are 2 times in a man's life when he should not speculate, when he can afford it and when he can't. And when we're losing 500,000 unit hours, 41,000 shifts, when we've got the problems we're having, we can no longer speculate. We need to be able to do this with data, and we need to be part of an integrated system. Thank you very much. It really is a privilege to be back in Copenhagen. Thank you very much.
Is Jerry spot on time? Anyone got any questions at this point? Stunned silence.
Okay.
You're saving them up for the end?
Yeah. Right.
Good.
Okay.
So we've got Ian Thomas next, who's going to come and share some nuggets of knowledge.
Have you got the clicker there, Jerry? Oh, it's on the stand. Fantastic. Hi, good morning, everybody. Can everybody hear me okay? Jerry's presented quite a comprehensive statistical analysis, I think, of the problem, and thank you for that, Jerry. It sort of gave me food for thought whilst I was looking at my presentation and thinking about what I'm going to say now when I stand up. Just to give you a little bit of an understanding before I start my talk, is I'm going to talk about learning from a military experience, to talk about something we need flow and not pressure. Up to 18 months ago, I served in the Royal Air Force, and I'd done 5 deployments to Afghanistan and 4 on the Medical Emergency Response Team helicopter. And I'm going to reflect on some of that, and you may think, well, what's that got to do with overcrowding in our hospitals? And hopefully I'll bring that working? Fantastic. What I will do is hopefully bring that point and make it salient to how I think that can describe into other systems. I wouldn't start this. I don't mind if anybody's got their phones out. I don't mind people taking pictures because it's important to tweet these messages out there. Hashtag EMS2017. If you want to follow me on Twitter, it's AndyThomas135 or @CypherMC. And I'm more than welcome afterwards to answer any questions for those who don't want to feel stand up on the process. As always, it's important to give you a couple of declarations. I am involved in various different things, like most people are these days. Clinically, I work as a critical care paramedic, but I do a lot of other things, and I just thought I'd declare them at the start. So I'm going to start off with my EMS 2017 guilty pleasure. And I'm going to thank Anne, who's sat over there for this. I was sat at dinner, on the faculty dinner last night with Anne. She's very entertaining, I have to say. Husband's in now as well. She kept me entertained last night. And this phrase was in the booklet, snatch a life from the jaws of death. And Freddie repeated it this morning, and we had a bit of banter about this. So I am British. We have an odd sense of humour. Our American colleagues, who I've worked with a lot over the years, like catchphrases. They like things like badges and coins, which I was presented with me this morning with the Jaws of Life logo on, which I was very thankful for as well. And I thought, well, what is this going to do with things? And that's our phrase here, one of the phrases from the conference. And I thought, actually, I'm going to take that as a guilty pleasure, because if we can snatch death from the jaws of life, thanks for repeating that for me there in the front row, miming it, then I think we can make a difference to patient outcomes. It's not always as glamorous as that, and as Jerry's presentation, I think, is pretty much shown, and certainly whoever's from London in the room will know that you're drowned and under the weight of urgent care. Not a lot of our business actually is this, but I think it's important what most people, when they go out in the emergency medical system to do, it is to make a difference to somebody's lives. That may be little Mrs. Goggins, but equally it can be more serious emergencies. So we've got Fireman Sam here, just to make sure my Welsh contingent felt comfortable. And obviously Jaws there, and old Fireman Sam's winching down Elvis to try and save the day. So, men do not learn from the lessons of history, and that is the most important lesson of all. And it does say men on there. So ladies, I appreciate you pick up lessons much better than we do. And you have the ability to multitask, which is something I still to this day can't do. I'm kind of walking around thinking, if I press the clicker and walk, am I going to fall off the stage? But hopefully not. And this is important. We'll look forward to what the solution is to overcrowding and problems right now. And actually, we're always looking forward. We're always trying to innovate, and I love a bit of innovation. But don't forget what we've done in the past, because actually there's so many lessons in the past of things that will teach us that can actually help us now in the future. And hopefully the journey I'm going to take you on now will explain a little bit about this. The next video you're going to see is about 45 seconds long. There's language in it, it's graphic, and it's a soldier getting blown up in Afghanistan. I will then do some still images to explain a journey of that patient, which is a different patient, because unfortunately the guy with the head cam in the first one didn't have the photographer on the helicopter in the second one, and it was a different one on the aircraft, but it's to give you the idea of how this works. And I'll do a bit of talking afterwards, and we'll just see how it goes. I'm just going to play the video in a second. We need to change things, because this, can you imagine that, outside of your hospitals? Is this something people, put your hand up if you've seen this site outside hospitals when you've gone in there. How can this work? Because the problem is, when all those ambulances are sat there, the hospital is buckling under that pressure, isn't it? The staff are stressed. I think the slide you showed about the stress. And we can't take any more. They close their doors, we sit in ambulances. Who's looking after those patients that are having the new emergencies on the street? There's nobody for those people. And that's why we need to look at how we change it. So, that was an ID going off.
Stay still. Stay fucking still. Stay with us. Stay still. Stay down here. Stay the fuck down. This way. You're gonna be alright, mate. You're gonna be okay. You put morphine on. Huh? No, don't fucking touch it. Stay still. Don't breathe. You can't breathe out. You can't breathe. Quick, boss! Boss, we gotta get him out now! Here, start to put the phones up together!
So, that patient did very well, but that started a cascade of events of patient care. It started a journey of flow. i.e. for him to survive those kind of injuries, and many of the soldiers, both Danish soldiers, American soldiers, and British soldiers that I was involved in caring in Helmand Province, it wasn't any link in the chain. It wasn't one thing that made a difference. It was the system that made a difference, and that's how you can change things. And I'm going to refer to it as flow within this talk. He's just stood on an IED. We're about 2 minutes into that incident now. His oppos are already on that radio, creating something called a 9-liner. We're at the base possibly, and we're getting activated to go on that job. It's a cascade of events. Whilst that's happening, the hospital are aware already, because it's all controlled centrally, and we talk about integration, and there's a whole system kicking in to support this patient. At plus 23 minutes, now this is his time frame, but a different patient just for image purposes, the helicopter lands on the battlefield to remove that, and you might, 23 minutes is a long time. 23 minutes is very quick in a battlefield situation. The aircraft takes about 7 minutes to get started up and ready to go. You have to fly to the job, you have to land safely, not cause any further casualties, and we're loading this patient on the aircraft at the 23-minute points with significant injuries, with what in previous conflicts would have been ultimately probably caused death. In flight, there's a team of people, whether it be the UK MERT, the American PJ systems, the Pavehawks, the Dust-Offs, they all provided life-saving equipment in flight. Within the British environment, we tried something different. We brought the hospital to the patient, not the patient to the hospital, because we wanted to improve that flow. And this is relevant now. This person, although he's in the back of a helicopter, he's not. He's in the emergency department now. And he's getting RSI, he's getting blood, he's getting advanced life-saving treatments, which will prepare him for what he ultimately needs to go to the surgeons. The team will work, often not speaking, working very hard. There's 4 medical team, a doctor, 2 paramedics, and a nurse, and there's some force protection aboard the aircraft that help out with other stuff. They're double-checking all the tourniquets. They're stopping flow. We want flow, but we need to stop flow in this particular instant, and therefore the tourniquets are going on to prevent further injuries. The blood products are getting given in. The team was so busy, the force protection guys who were not medically trained, we trained them to set up blood bags and check them for us before we administer them to keep that speed of treatment going. Because these flight times, my shortest flight time where a patient was 90 seconds. What do you do in 90 seconds after you've just picked up from the battlefield? Actually, you can do a lot when the team's working well, because you know that hard work in that 90-second period will get them into surgery 2 minutes quicker down the line, and that could be the difference between life and death. We come off, we land this was a Nightingale at Camp Bastion. The patient's getting brought off by the force protection, the medical team, 1 or 2 people get off with the patient. One continues to care for the patient, the other one goes off ahead and starts handing over. Because we don't want to hand over when the patient's in there. We want the team to know what's going on before we arrive in. The patient's coming into the front door, plus 41 minutes now this is. He's getting handed over to the emergency department. The handover's already taken. There's a whole team of people, 20-odd people around him, with all the surgeons stood back here, who've listened to the handover, watching what's going on, and thinking what we're going to do next. Where does flow come from here? There's somebody from the Aeromed cell stood there, off to the side, not saying a word, writing all the notes from the pre-hospital handover, writing all the kind of immediate injuries, and within 2 minutes they'll walk off, pick up the phone, and activate a CCAS flight from the UK or a CCAT from the Americans, and there'll be a team starting to prepare to fly to get this patient to the next level of care already, and he's not even left the ED department. We're 41 minutes into the care. At 55 minutes, he's in surgery. That surgery, that operating theatre is 10 metres away from the other bed you saw him in a minute ago, through a set of doors, no moving around, and that flow of the system keeps things going nicely. You can see the surgeons and the surgical teams are working, but you've still got members of the ED finishing off the stabilisation process. Plus 16 hours, the patient gets onto a C-17 and he's on his way back to the UK. Plus 16 hours. Can you imagine if we get some of our medical patients moving through systems that quickly, how much of an impact that would have? At plus 23 hours, less than 24 hours from standing on an IED and losing limbs in Afghanistan, the person's back in the Roll 4 treatment facility. He'll have landed, he'll have a police escort to this hospital, which was the Royal Centre of Defence Medicine, as part of the Queen Elizabeth Hospital Trust. And he'd arrive there, and immediately there'd be a team who already knows his full history. They've had discussions with the surgeons in theatre, and theatres are ready for him to go in for more damage control surgery when he arrives. And everyone thought this was an amazing system we developed in Afghanistan. It's like we were geniuses. Everyone invented it as well. No, we didn't invent it. It's basic, simple flow. This is a flow diagram from the World War I. It's nothing new. It's nothing we've suddenly thought of in a military setting. Some of the medicines changed, some of the boundaries were pushed, but somebody gets injured. In those days, we just carry them on a stretcher. Nobody really do any treatment. If you survived, good. If you didn't, tough. They'd go to a regimental aid post, have a little bit of patching up. They'd go onto the motor ambulance with, obviously, and be transferred to the next stage of care. They'd be in a casualty clearance station. They'd go on the hospital train, and then they'd eventually get back to a hospital. And then they'd spend weeks in these hospitals, weeks in them, clogging it up. But it got them off the front line. The same model, but in a different era. Almost 80, 90 years difference, but still it's got a lovely flow going through it. So, it takes a system to save a life, and you need flow, not pressure. How is what I've just said applied to any of the stuff we're dealing with now? How is that going to change things? Well, actually, it's about a mindset change. Everyone in that chain of survival, that was their dedicated role. They were specialising in trauma. They didn't, I appreciate, have the 95% of the other work, clogging up the emergency department with coughs and colds and all the other stuff. Little Johnny's got a temperature. I ring 111, and almost every time if it's a child, you'll probably get an ambulance, and that kind of care. That system wasn't there. But how do we apply that to our healthcare systems? Do we super specialise? Do we break it down so we have an ambulance service that responds to emergency care and an ambulance service that just responds to urgent care? In our country, GPs used to do that. You'd ring your GP up at 4:45 because little Johnny's sick. He didn't want to get a call at 10 o'clock at night because he wants to go and have a kip and stay at home with his family. So he used to sort you out there and then, and clinical advice was appropriate because he was trained in carrying risk. That doesn't happen now. We go through call takers. I think Jerry mentioned there was clinicians answering the phone. I think, unfortunately, in the UK, we have a lot of initial call takers, not clinicians answering the phone. I think that needs addressing, and we might get better results from that system. And about 15% of those calls result in an ambulance disposition. It's a safety net of the system. 15% of calls, when you're ringing up to speak to a GP, are potentially going to result in an ambulance. That can't help reduce the burden on the system. And these people, the people from world wars, from probably the Second World War, still alive now, not so much the First, and we call them bed blockers. I'm going to get old. I'm probably going to end up in a nursing home, and at some point I will end up in nappies again like the day I was born. It's probably going to happen to most of us, so we may as well accept it. But these are people who've served our society for generations, often in the most difficult times that we probably can't comprehend these days, and they go into hospital, and 30% of them we can't get out the back door. And that stops flow. And we call them bed blockers. That's a terrible word. Would you like to be called a bed blocker? I'm sure, and it's in all the papers and stuff, and some of them even bring their own beds to hospital now, as you can see from the hospital, because they've heard there's a crisis with beds, so they're bringing their own bed. Do you think these people want to stay in hospital? No, not at all. I mean, I don't know what it's like elsewhere. Hospital food in the UK could be improved, I suspect. And therefore, these people want to be back to their families. They want their independence. They want to be back with their loved ones. And 30% of these people, there's nowhere for them to go because there's no care in the community, which is the big phrase in the UK. There's no social care in place. Budgets are strained. It's not my problem. It's your problem. I don't want to spend it on my budget. I want to spend it on your budget. And these are things people in the audience would probably battle with. Hard-working hospital clinicians are always battling with where they put their patients, how do they get the right care, and they cause a problem. We shouldn't think of these people as bed blockers. We need to think, how can we get them the right care and get them back in the community? Because I don't think they want to be in hospital. I think they want to be at home with dignity, with respect, and I think that's a really important thing to remember. So, rather than just rant on about there's a bit of a military flow and how does this apply, I had a little think and I thought, I didn't put, we give blood, not coins on this one. I changed it for you. I thought, let's stay calm about this. Let's not panic, and let's think smart. Now, we've got the 5-year forward care review in the NHS, and we're looking at that to revolutionise things. And we've got things called STPs springing up around our country. I don't think they're well integrated at the moment. They're all doing their own things, and they've all got their own budgets, and I think that's going to cause stress on the system. We need better and more social care. I'm not going to get into politics of what our politicians are promising us. We all know they lie to us, whether it be about how much we'd save from Brexit. I thought I'd bring it up at some point. To how much they're going to be great for us. We all know politicians lie, but we do need better social care. Because if you can't get the back door emptied and the hospital's full, we can't get people in the front door who may need further care. We need to manage expectations. I think, and certainly in my own country, and I'm speaking to colleagues from around the world over the last 24 hours, it's amazing how some of the problems are the same, but some of them are a little bit different. Manage expectations. People think you pick up a phone and call 999. People think their healthcare needs to be addressed instantaneously. It doesn't. If you've got a 2-week history of chest infection, yes, you're going to have some chest pain with that. Yes, you're going to get an ambulance, but because 111 will draft one out to you. And then when you get left at home, don't be surprised. You've got a chest infection. And that's what we've got to manage. We've got to manage what people think they should get an ambulance for, or what they should be in hospital for, or when they should be discharged. Nobody wants our bed blockers or old people home at Christmas or on holidays because they've got their own problems, and we need to address that. Align the budgets. Why do we have all these separate budgets? Everyone fighting it. In my country, it's all public money. It's all taxpayers' money that goes into the system, yet you'd think it was coming out of individuals' pockets when we're trying to sort out healthcare. And I think our budget system of financial years, and one department has this budget, one department has that budget, creates the crisis that we have. We need to reduce admissions, increase advance in practice. That's happening with paramedics, advanced nurses in the community. All these people are massively reducing admissions in the country. If I'm off the cuff, Mark, I'd really like to see some actual GPs get back to doing GP work and seeing patients, because I think they can do it much faster than APs can, and that would save money in the long run. And remember, guys, teamwork makes the dream work. And if we all work together as a team and all think we can do it for positive for the patient, if it's trauma, we'll love it. We're all keen to go there and go the extra mile. A cardiac arrest, we all want to be there. But we don't want to be there for Mrs. Goggins, who's got a polypharmacy of drugs, and she's got a bit of a hypertension suddenly come on. So, to summarise, you do need flow, not pressure, to reduce overcrowding in the hospital. You need a system to make a difference to somebody's life. And if the military experience has taught us anything, if we work dedicatedly together and don't worry about budgets and all the other problems, we can find solutions, and hopefully that will help improve the crisis of overcrowding. Thank you very much.
Andy. Are there questions that are coming out? I think there are certain themes that are arising. One, which is the whole theme of the conference, which is about complete systems. And you told a story there of the soldier who had treatment right the way through to almost sort of definitive care, reparative surgery in 23 hours, which is amazing. But each one of those stages is important. And again, with Jerry's point, which was about using EMS services in a very innovative way, including the care bundles once they're home. We need to look at different ways, I think. But I'm yabbering on. I'd like to invite any points that there are in terms of this speaker. We will be collecting some of these thoughts at the end. But any questions?
No, stunned silence at the moment.
Stunned silence. I think their brains are overcrowded.
They're obviously waiting for Jerry, the main man. So
Freddie, rather.
I'm sorry,
you've got Freddie,
even, sorry.
Well, thank you so much.
Nope.
That was really illuminating, and it's with great pleasure now. Sorry, quite right, thank you. And it's with great pleasure now to ask Freddie to come to talk about a Danish perspective and also in context of the theme of delivering care. Thank you, Freddie.
Thank you very much. I just want to rate these 2 sessions I've heard, the 2 speakers. They were very good, so that's great. I'll try to follow up on the theme there, because Jerry told us about that this is an international problem with crowding in hospital and the effect on the EMS system and the other way around as well. And Andy told us about it means flow, and you came up with some very good solution and patients' perspectives, I believe. So what I'm going to do is to tell about what we have touched upon now. It's an integrated EMS solution to solve these problems. We have worked with that for 3 years, and I'm just going to show you a bit of that. My Twitter is there. Conflicts of interest or acknowledgement to the Danish Tryg Foundation and Lerdahl Foundation. And this presentation will then short be about EMS Copenhagen. That's just so that you can relate to the solution that we have implemented. And what is an integrated EMS solution I'm going to tell you about, and what did we achieve, some data on that. And just to give you the summary, we actually came from an outsourced and fragmented delivery of care to integrated care, and leading to an innovation EMS system, which is some of it we have heard from Jerry, and in some systems that you praised, but we are, in my opinion, we actually got it further on for some of the issues there. We have the general EMS system with dispatch, ambulances, physician cars, helicopters going out, and we also have the medical helpline or hotline, which you would call. But the important thing here is the command and control center, which actually makes flow happen. Not pressure, but flow. And just to tell you the short story of the political part here is that in 2008, we had a new political plan for EMS in Copenhagen and the capital region, lining up what is the perspectives from a patient's care. And it was to make it easier for the patients to find the right solutions and the best way. Then we have different solutions coming up with a new tender on ambulance services. We got new IT system, and then we got, which we hadn't had at that time, we got all the emergency calls coming into the dispatch center. Before that, we were just taking care of the logistics on the vehicles dispatching, but now we also got the emergency calls, so making triage and prioritization there. And then EMS was established as an independent corporation in Copenhagen. Then we had a separate telephone number, 1813, which was meant to be for help, advice for people initially. And we had a pre-hospital mobile psychiatric unit also coming in, and we moved to new facilities. And in 2014 we had major change. We'd actually integrated all the emergency care in the Copenhagen area into the command and control center or dispatch center, because we got a medical helpline 24/7, making it easy for people to get access to the best help, and even schedule a time, booking a time for them in the emergency department. And that solved some of the problems. It created others, I would say. So just to say, what is the command and control center taking care of? Of course, medical dispatch, but also health-related emergency calls, and medical helpline for all other not life-threatening injuries. It's urgent and it's not urgent. Just to give you a few numbers. So, for instance, we're serving 1.8 million people in Copenhagen. We have 130,000 calls to the life-threatening number, 112 in Europe. But we have nearly 1 million calls to the medical helpline. For people who want to go to the emergency department, or people who don't know what to do, or people who don't know where to get help, they would call us. That results in 250,000 missions by vehicles per year, which is actually a lot. And 60% of these are first priority, urgent. So we haven't, in that period, we haven't seen an increase in ambulance demand as you have seen in UK or other big cities in Europe. We have kept it nearly stable, but we have seen a change in pattern of priorities. So just to say about the reorganization then, just is to illustrate how it was before and how it is in many systems. You have the patient in the middle, and they can choose. So they can call one number or another number, go to the GP, they can call a friend, they could go to a hospital, might be the right one, might be the wrong one, they might be closed for these kind of diseases that they have, or because we make a lot of changes and centralized care, they could go to the emergency dentist, they could call the mental health care part, or they could go to the GPs. So it is actually, they have a lot of choices, but even I wouldn't know what number to call and when to go with what disease, because you have to have a lot of knowledge about the specific healthcare system that you actually have. We changed that. So we changed it and we kept the emergency number 112, and then we introduced another number, which is 1813. So if you get in a situation in Copenhagen where you need life-threatening or support for life-threatening or supposed life-threatening injuries, you call 112. In all other cases, you call 1813. But as you can see, you have different responses. So you will, So you will either get a response on vehicles if it's life-threatening, But those calling 112, about 75% will get an ambulance. About 25% don't get an ambulance because there's no need for an ambulance. They will get advice about other care, or they will be transferred directly to the other number. The other number, if you call that number, you will have all the lists, and it's up to the nurses and physicians on that number to decide what is the right solution for you based on what you tell them, based on what your need is. So we, not like in UK, we have they have call takers who will help people and advise them, but we have, so the triage in our system is made by nurses and physicians, and it's 24/7. And in addition, you will get scheduled the time in the emergency department. And this is how we avoid overcrowding in the emergency department. We have had in Copenhagen an increase in people going to the emergency department for years, and we have had long waiting times in the emergency departments, hours and hours, but it has changed. I'll give you some few data for that. And that is because people would call this number, they would get advice, they will be triaged, some would refer to a general practitioner, some would refer to self-care, get advice there. Others would be referred to an emergency department. And if you can wait for 3 hours, we will advise you to do so, and we'll book a time for them. Maybe they cannot even go to the emergency department within 1 hour, so we'll book a time for them, and then they'll go to the emergency department. We send the booking to the hospital. We know the capacity of the individual hospital, and we can actually say, we got 2 choices for you, 2 hospitals. One you can choose, though, but you can come there in half an hour. The other one, it will take 2 hours maybe. And people that can then, what is appropriate, and if they want to go, and if they do have time to do it now, they can do that. And we get feedback in our IT system about the capacity on the individual hospitals. But sometimes we don't have more capacities. And then we, on a fairly way, try to distribute the calls and the demand to all the emergency departments as needed. So they will just be informed that now we have to send more patients that you actually can absorb, but it's a common family, a common solution, and they will accept that. That's the same with the ICU. If you have patients who is going to an ICU, you cannot just close an ICU because you don't have any more beds. The ICUs will then have to open more beds, reorganized, but we try to make it fair between the different hospitals. So 2 numbers, 1 dispatch center. For the first number, 112, it takes 4 to 5 seconds to get through when you call, in average. And the other number, it takes minutes. The goal is to get 90% through in 3 minutes. That's impossible. But we get around the average response time or answering for these calls is about 3 minutes, 3 to 4 minutes. But then when you have 400 calling in just one, oh, what a balloon. We missed 1 patient. So I'll see if I can save it. I will. So in the other number, we will sometimes have difficulties in answering. We might get 400 calls in 1 hour, and with the capacity we have, then people will just wait. But we do have some patients who can go first in line, but in the end, when we look at it, less than 2% of those patients calling the 1813 will actually get an ambulance because there's no need for an ambulance. So it tells me that the patients do know which number to call. What is the impact on the emergency department? This is data on urgent care. Of course, if it's life-threatening, we'll send an ambulance, go directly first in line in the emergency department. They will be told by the ambulance crew, they will send the information, electronic information to the department or call them, and they will be prepared for that. But if we send them and say, we're not sure, you don't need an ambulance, you don't need treatment during transport, you should go to an emergency department, but you need to go there. You cannot wait for an hour or 2, so go there now. And we will tell them up front that you are coming, what is the disease, what are the symptoms, and that we want you first in queue. And then time from arrival to start of treatment is now in average 9 to 11 minutes. It used to be hours. It's now 9 to 11 minutes. And that's because we have the flow, but we put some in the queue for saying you can come in 3 hours, or you can come in 4 hours. It doesn't matter with the disease you have. And for those, and the total time from them calling, waiting in line, getting in contact, finding out what's going to happen, say to the patient which hospital they should go to, and maybe they cannot go there now, but will wait half an hour. And when we send them there and they are all treated, it takes 60 minutes for those patients in total. For the non-urgent part, it is 27 minutes, and it is 93 minutes. We have a goal I'll show you that later. We have a goal in the emergency department that people should be seen within a certain time limit. And it used to be red in most of the hospitals. Now it's all green. So what is the advantages of this integrated solution? Well, first of all, it's easy and simple for the citizens and for tourists. And you can even call it, if you're Danes and going abroad, you can even call that number. And people do that from US and Australia, calling middle of the night and saying what kind of complaints they have and if we can help them. Yeah, we can help them, but we cannot send an ambulance, but we'll advise them. So any kind of medical need or questions for all patients, they can call. We have the shortest waiting time ever in the emergency department. That is due to the system, but also due to the work done in the emergency department. They reorganized the flow there. We also have the best use of the capacity and resources for 24/7. We just went to electronic patient chart in all hospitals, the EPIC system. And during that process, for instance, this weekend, the one hospital was closed down nearly for 24 hours because they were going to electronic charts and have to reorganize it all. And it didn't make a difference because people would call us and we would refer them to other hospitals. So this kind of impact you can actually control in major incidents or planned incidents where people should go and what is the best use of them. Otherwise, they would just be queuing up and that couldn't be treated. And if the hospital calls and tells us we are ready to achieve more patients now, we just open it. It takes a few minutes to change the systems to do so. So emergency department capacity and ICU intensive care unit capacity is available at the dispatch center, and also preparedness for operational coordination. And then, very important, we now for the first time have available data for planning. We actually didn't know before what happened to the patients. We have the data because they call these two numbers. We have the social security number. We can track these patients and we can use the data to improve our system all the time. Before that, we didn't know. This is the waiting time in a telephone line. 9 minutes in the beginning of January. Now it is end of January, it's about 3 minutes. So we have improved a lot. We have been criticized for having too long waiting time in that line. The patient doesn't care because they know it's not urgent. But of course they should get through as quickly as possible. This is the calls from 2014, 15 and 16. It's so consistent, as you can see. It depends on the month, but it's actually so consistent. So you can nearly predict the number of patients who would call today at the end of the day. Plus minus 10, actually. A normal day, we'll have 2,000 calls on that number. On a weekend day, like yesterday, we'll have 4,000 calls. And what is the response for these patients? Some is being, you don't need to read the English one, or the Danish one, but it's just to say it's so consistent what happens to the patient. A certain number would go to the emergency department, refer to that as priority, high priority, and others as not high priority. Some would go have a home visit, some would be referred to their general practitioners, and some would be referred to self-care. And these are the visits in the emergency department. the blue line, as you see it here, the upper line is straight, meaning actually this is an average because we don't have data at that time before that what actually happened. But we do have the total number there for the year. But the other lines are the people that we referred since then, 2 different years. As you can see, it decreased. 10% less people are going to the emergency department. I know the emergency department think that they have much more patients there, but it's because we have emergency department, we have patients who were going to the GP's clinics there, but now it's all integrated. So in total, we actually reduced the number of visits to the emergency department by 10%. And that's a lot, while others are seeing an increase there. This is the emergency department fulfilling their waiting time before seeing the patients and treating the patients. As you can see, it's all green and has been there ever since 2014. Patient satisfaction, we sent out 200 SMSs to people who call us and say, were you satisfied with the treatment you got? Did you get the help you needed? We have a response rate saying 90% yes. And you cannot make everybody satisfied. Some would like one solution or another solution, but we don't think it's reasonable from a medical standpoint, but actually 90% are satisfied. So just to conclude, we had it all in the very beginning, but it was disintegrated. We tried to put it together. But to do so, we need to have a system, and it takes a system to make this work, and it takes collaboration between different units, EMS, dispatch center, emergency department, and also citizens. And that is the great thing about that. So in summary, we managed to establish an integrated EMS system within this 3 years actually. For the first time, we have one easy access point for citizens 24/7, and that is the emergency department. 2 different numbers, but very easy for the citizens. And for the first time, we have data available for planning and for research as well. For the first time, emergency departments are now fulfilling their demands on the waiting list, and we have a reduction in emergency department visits by about 10%. And it does also have an impact on the ambulance services, but we have different people going in another way. I do have other data, but we don't, in the interest of time, will be able to show those. For instance, we have been criticized for the time I mentioned for too long time before the telephone is answered. It was also being criticized for having too many complaints. Well, we have about between 15 and 20 complaints per month. But we have 80,000 calls per month. 80,000 calls per month. And some of them would be, well, you know, some of these complaints, but some are right as well. But for the first time, it has been very transparent to us what is actually going on. So we pick up, and we are able now to pick up most of the unintended things that is happening in the healthcare system, whether it's on GPs, emergency department, or when they call the number. And that is that's a benefit, because it makes it possible to actually improve. So thank you very much.
Thank you so much. Excellent.
Almost 10 minutes left. I know people will be desperate for lunch by now. I've got one question to get started, which is for Freddie, who's disappeared.
He's there.
Oh, he's behind me. He's behind me. So I'm going to go over here, which is, we've got 2 numbers in the UK. So we've got 111 and 999. It clearly does not work in the same way that yours does. I think one of the sort of clues to that, and one that we've become to recognise, Andy talked earlier about quite a lot of our 111 calls are taken by non-clinical call handlers, and there's a real recognition that to try and make that more fit for purpose than it is at the moment, that we need to increase the number of clinicians we've got doing that. And the same in terms of trying to increase hear and treat within ambulance services. The problem we have is we also are, it's becoming increasingly apparent that we've got a skill shortage. So emergency medicine is struggling, primary care is really, really struggling. Huge vacancy rates for paramedics, and so everyone is trying to fish in the same pond. You've obviously managed to do that, and I just wondered how easy it had been, and both to recruit clinicians to working on a telephone helplines, and also to retain them. Presumably, it's come to be seen as clinically a desirable job to do, and I just wondered how easy that had been, or whether it's been difficult.
First, when we got the emergency number 112, we thought that it might be, and it was difficult to recruit people for that number. It's nurses and paramedics taking these calls, and it was. But I think it's a very important, and it's maybe the most difficult part, because if you see a patient in the trauma center or in the battlefield, you can see all the things there. If you see it in an ambulance, you have limited information. But when you have the call only, you have to make a decision based on that. So it's a difficult one. We actually managed to get people on board for the emergency number, paramedics and nurses. And I think that does make a difference whether it's healthcare professionals or not, like in other systems. For the 1813, which is equivalent to 111, except that we have healthcare professionals. We have struggled in recruiting people as well, because you don't want to sit, or maybe you don't want to sit and answer 2,000 calls per day and have a lot of night shifts and things like that. But it is a very important job for the. I think it's important, and what we try to, for the citizens, and they are satisfied, and what we try to do is make a balance between what you can actually do different things. So we have trying to create so that you can work in an emergency department half-time and then be on the telephone in our system. We didn't do that in the beginning, but we couldn't recruit enough nurses, so that was created. As for the physician, it was easy to recruit physicians for this, to take as a part of their other jobs, but then we had a struggle with the GP union in Denmark, meaning that they said that the members shouldn't work in that system because it wasn't controlled by the GP organization. And we have struggled with that, and even now, but we have 180 physicians in that number, and I think we have about 80 nurses with emergency background, most of them.
I think that's going to be one of the keys to that's going to be one of the keys to us trying to improve the system we've got, is have much more clinician buy-in than we've got at the moment. Does anyone have any questions, comments, experiences? Oh, we have someone down the front.
Is there a microphone, please? Is there a microphone, mate? Yeah. I'll go mobile. Is it on, is it? Yep. There we go, sorry.
So I have two questions. One of them is how did you overcome the issue of some emergency services being a fee-for-service system, and in that way having an interest in transporting patients to wherever? And the second question would be, I don't know if this is working, and the second question is, how many people does your throughput system demand per patient?
Do you want to answer the first question?
The first question was fee for service, or what was it, please?
So yeah, it was based on transport, and was there any effectively pushback, is my impression, because obviously people get paid to take people to hospital.
Yeah, we don't have that system in Denmark. I'm glad we don't have that system in Denmark. It is so that it's for free to call, and the services is free, but we get a budget, and for that budget we have to make sure that people get the help that they deserve and is right. So we try to tune up that system so that we don't go up with ambulance or we don't crowd up in the hospitals, and this has helped us a bit. But we are not paid per ambulance, so if we can find other solutions of bringing patients, we have a social ambulance helping people before they need an ambulance, or if we can make home visits and things like that, then we reduce that time. But the whole budget is within the EMS. So as long as we can find a good solution for the patients, we can do what we want with that budget.
Can I, just ask on Jerry for sort of an international perspective about how fee-delivered transport services, how you think they may affect the efficiency of a system?
I don't.
And that's a 1-minute answer for a hugely complex question.
I'm not sure that you see a relationship amongst fee-for-service ambulances and actually efficiency.
Mm-hmm.
I mean, it'd be generalizing, and because I know some fee-for-service systems, I would call it, are incredibly efficient, but I can also tell you that I am very aware of fee-for-service systems that are incredibly inefficient. And likewise, I know of systems that don't charge a thing and are incredibly inefficient, and I know of that don't charge a thing and are incredibly efficient.
Yes.
So it's really, I think it goes back to the actual EMS system design and the components of that EMS system design and how those components come together to formulate an overall, what we call a performance-based system.
Yes.
And so you kind of separate actually the budget process from the efficiency. So
yeah.
I see both from an international perspective, to be honest.
Sure. I think from your talk, one of the key things was about the efficiencies, and also from Andy's and Freddie's, is about the patient journey moving across a whole systems approach.
And it's how it's designed and integrated. Yes. So it really is based on the system design itself.
Thank you.
So your other question, I believe, so I'll come on to you, Madam, 2 seconds, was it the military system, how many that's staffed? So it was staff intensive. So on the helicopter, there was 4 medical teams, 4 people operating the helicopter, 4 people shooting the baddies when we went on the ground and stuff like that. And the whole system was intensive. But I think what you have to put it into context of, obviously you couldn't repeat that system across the board. But because you create flow in the system, it actually would save you money in the medical system, I think, because it must cost a hell of a lot of money when, in our country, we fine ambulance services in hospitals for queues and things, and therefore, if you created flow, it probably costs more to create that system, but would save money, I speak, but I'm not an health economist. So
in terms of speaking for the UK picture about the reorganisation of service to major trauma centres, where other hospitals are bypassed, it's been shown, certainly for London, in 2 years of data initially collected, that there were 72 lives on basis of previous data, 72 lives which have been saved by reorganisation and allocation of major transport services, modelling on the North American system. So there are costs inherent, but there are also better clinical outcomes. And so and that's why it was a really interesting question about, should we have specialist EMS services? And with the Danish system here, you have an acute psychiatric facility, an acute social system. And this is a very smart way of working, I think. But again, that's just my own personal opinion on a UK basis.
Hi, Jerry, you were talking about the hear and treat system. I guess it was part of the UK system. Is it within the emergency medical services, and how is the treatment organized? Is it by is it treatment or advice given by the call handlers, or are the calls referred to physicians?
I'm sorry, I can't.
Hear and treat, Jerry. I think the question's on hear and treat. Is that correct?
The hear and treat.
Yeah, hear and treat. You mentioned hear and treat in your presentation. Right. She just wants a bit more explanation.
And what is your question regarding hear and treat? I'm sorry.
The question.
How does that happen? As far as hear and treat is concerned, it happens in a. It happens with a specific algorithmic interface with typically either 999, 911, or 120. Yeah. There's a algorithmic for hear and treat coming. You're assuming you're coming through the emergency number, correct? Typically, it's an algorithmic, regardless of what kind of dispatch system you have. It's an algorithmic protocol that comes through that when you get to the lower acuity level in a triage system, in any type of dispatch triage system, it interfaces to a nursing system, and that nursing system does hear and treat. And just like what Freddie talked about, I thought what Freddie talked about was incredibly important, because essentially they have an integrated directory of services off of their 1813 line. And that directory of services that Freddie has would be available to the hear and treat portion of of either the communication system or the adjunct system that's going to be doing the hear and treat. So it's going to be it's going to be very dependent upon the availability of a directory of services and providing that wide range of services that Freddie talked about. I mean, It's brilliant what Freddie is doing. I mean, he even talked about dental services and social services, and that's what's got to be interfaced. So it's a systemic integrated approach that goes from high acuity to low acuity interface, and then the nurse advice line or the hearing treat advice line does another algorithmic, goes through another algorithm and provides the directive services.
We're going to have to stop now because we're running over, and for every minute that you run over, it's 10% decrease in survival rates for the next session. So that would be unfortunate. But can I ask you to thank all our speakers for really a marvellous section. And I'd like the lady in red to identify the speaker that she wishes to address at tea time. Thank you all very much indeed.